Hi, everyone. As mentioned, I'm Ellen. I'm a clinical pharmacist who specializes in neurology, primarily caring for patients with Parkinson's disease, multiple sclerosis, and other neurodegenerative disorders at UC Davis Health in Sacramento, California. I have no conflicts of interest to disclose. This content was developed for you all, a patient and care partner audience, and is intended to be educational. So the outline was kind of already mentioned, so I will just jump right in. So, starting out with what Parkinson's disease looks like, we often talk about the main presentation in terms of either motor symptoms, meaning affecting your movement and balance, or non-motor symptoms, meaning not affecting movement. To first summarize the common motor symptoms of Parkinson's with an acronym, we can think of TRAP. So T for tremor in one or both hands, R for rigidity, you see limited motion or stiffness, A for akinesia, which is lack of movement, you may suddenly freeze up or be unable to move, or bradykinesia, which is slowing of movement, almost like moving in slow motion. And P is for postural instability, which is impaired gait or walking difficulties, like pictured here, a slightly stooped posture as you walk, shuffling feet with very small, frequent steps. So now pictured here are several of the non-motor symptoms that can present in Parkinson's, things like loss of sense of smell, sleep problems, constipation, depression, daytime sleepiness, memory problems, drops in blood pressure, especially with position changes, and hallucinations. So seeing or hearing things that are not there. I could honestly give a whole other presentation on how to manage these non-motor symptoms of Parkinson's. For the purposes of this presentation, though, we'll focus on the medications for treating the motor symptoms of Parkinson's. So, why do these things happen? Well, we have a very important balance of chemical messengers in our brain and body, dopamine being the one of these key chemical messengers, playing important roles such as controlling our movement. So, since in Parkinson's disease, the issue is a loss of these dopamine producing brain cells, when you have low dopamine, you have less movement. So comes on the stiffness, the slowness, the tremors, balance and coordination problems, as mentioned, which is often referred to as off time, or again, the motor symptoms of Parkinson's. And this is relevant because many of the medications that we use to help treat these movement related symptoms of Parkinson's are aimed at restoring the balance of brain chemicals, primarily via dopamine pathways. So here's a summary of key medication treatments. This looks really complicated, but I promise I'm going to try to simplify it. So stick with me. We're in the brain here, and a dopamine producing neuron, which is a brain cell, that's not producing enough dopamine, like in Parkinson's. So most of these drug treatments for the motor symptoms of Parkinson's are aimed at doing one of the following things. So one, directly replacing dopamine, which is levodopa. Two being blocking the breakdown of dopamine, thereby preserving the amount left around in the brain, which are the COMT inhibitors and the MAO-B inhibitors, or acting as a substitute or a mimic for dopamine, which are the dopamine agonists. And we'll go through all these step by step. So, first thing you can do if you don't have enough dopamine is directly replace it. So, how do you get dopamine back in the brain? So, unfortunately, you can't just dump pure dopamine into the brain. You need to get it across what's called the blood-brain barrier. Therefore, levodopa you give, which is actually a precursor to dopamine, but by itself, it unfortunately will just break down in the body circulation and not make its way over to the brain. Therefore, levodopa is given with carbidopa for a reason, and this is to prevent it from prematurely converting into dopamine in the body circulation and allowing it to cross its way over through the blood-brain barrier and get into the brain to do its job to help manage the motor symptoms of Parkinson's. So there are several formulations that have been developed of carbidopa levodopa. Many of you have likely heard of them. Sinemet, carbidopa levodopa in its immediate release form or controlled release form. There's extended release products such as Rytary or Crexont, or there's other forms of even inhaled levodopa, and now the newer infusion pump form, which we'll discuss later on in the presentation. So another thing you can do if you don't have enough dopamine is block it from getting broken down. So preserving the amount that sticks around in the brain. One of the drug classes that does this, it preserves the amount of dopamine in the brain is called the COMT or COMT inhibitor. A common example being entacapone. And this blocks the breakdown of levodopa. Then, along with carbidopa, it can, as mentioned, make its way into the brain. And therefore, COMT inhibitors are actually only useful in combination with carbidopa levodopa. In fact, there's actually a combination product out there called Stalevo that contains carbidopa levodopa and entacapone all in one pill. And another main class that helps preserve the amount of dopamine in the brain is called an MAOB inhibitor. A common example you may have heard of is rasagiline or the brand name Azilect. And so MAO actually plays an important role in the breakdown of brain chemicals, including dopamine. And the B type of MAO is specific for dopamine. So by blocking that pathway, you can actually preserve the amount of dopamine in the brain. And these medications can actually be used by themselves or as an add-on treatment to carbidopa levodopa. However, their motor symptom benefit is not considered as good as the levodopa products. And they're actually, you may have heard of drug or food interactions that have been flagged either on the internet or the pharmacy counter with these medications. But they're actually not of typical real world concern because these MAOB inhibitors, when used at recommended doses, are selective for dopamine, not the other brain chemicals that are likely to lead to these interactions. And we'll go into detail later on in this presentation when we talk about common drug interactions. So the next drug class that can increase dopamine is called the dopamine agonist. A common one you may have heard of is ropinirole. It works primarily by directly stimulating the dopamine receptors here, activating and mimicking increased dopamine levels. So similar to MAOB inhibitors, these medications can be used by themselves or as an add-on treatment with carbidopa levodopa. However, this class of medication has actually fallen more out of favor due to the side effect potential. For example, impulsive behaviors are more likely with the dopamine agonist class, though they are possible with other therapies that increase dopamine as well. And we'll talk more about the potential medication side effects later on. But oftentimes, when we use these medications as add-on therapy to carbidopa levodopa, we'll actually need to decrease the doses of the carbidopa levodopa to minimize side effects. So there are a few other types of medications that we use that I want to touch on briefly. Gocovri or amantadine is one that we don't fully know how it works, but it's the only medication oral treatment for Parkinson's that we can use to help with both too much movement, which we refer to as dyskinesias, or those uncontrollable jerking, bobbing, or swaying movements, and with the not enough movement part. So that off time, which we talked about with the Parkinson's trap symptoms. It's also used as add-on treatment to your carbidopa levodopa regimen. And so I talked about at the beginning, we have this very important balance of chemical messengers in the brain and the body, dopamine being the one key chemical messenger that's low in Parkinson's. So without enough dopamine, it can tilt that balance to another brain chemical called acetylcholine and can lead to too much acetylcholine, which can then stimulate the muscles to contract, leading to things like tremors. And therefore, there's this class of drugs called anticholinergics. One you may have heard of is called benztropine, which blocks the acetylcholine and helps correct that balance with dopamine. And these medications are mainly helpful for tremors. And their use is actually becoming also less favored because of their side effects, especially in older adults, because they can cause things like confusion, constipation, and drying effects, which some people may already be experiencing at this point. And so this last medication we'll discuss here is a unique one. It's called Norians, and it's actually the only one in its specific class, and it doesn't directly act on dopamine like many of the other medication classes we discussed, which can be beneficial in reducing the likelihood of some of these dopamine-related side effects. So we can think of a car analogy for how this one works. While activating dopamine receptors is like pressing on the gas and starting movement, activating adenosine receptors is like pressing on the brakes and stopping movement. So if you block someone press on the brakes, then you're essentially allowing the car to start rolling again. So you're increasing movement, but a little bit more gently. So Norians is used as an add-on treatment to carbidopa-levodopa to help with reducing the overall off time per day by about 1 hour on average, which isn't a huge amount, but it tends to have less side effects too. So it tends to be more of a mild add-on therapy. And so we talked about not enough dopamine and how medications we use to help increase dopamine, but we also talked about the importance of balancing brain chemicals because on the other side of things, too much dopamine is also not a good thing. It can lead to side effects. An important one being we talked about dyskinesias, what I like to describe them also as the wiggles or dance-like movements. So you can see it's all about a balance of what we called motor fluctuations, minimizing those like pictured on the teeter-totter. We don't want to tip it too much or too little. We want to be in that good on-time range. And as discussed, our gold standard treatment for Parkinson's is a levodopa-based therapies. But over time, it may seem like your levodopa becomes less effective, which can be discouraging to continue to need larger doses or more frequent doses of medication to control your symptoms. However, it's really all about replenishing the low dopamine from more of the dopamine producing brain cells dying off in the natural Parkinson's disease course. So, since levodopa unfortunately does not slow the disease process itself, it's all about managing symptoms just in order to maximize quality of life. So, as promised, we'll take a look at some of the different forms of carbidopa levodopa. These forms differ essentially in how the medication is released from the body. So, there's the immediate release form, which is the fast acting form, while the controlled release and extended release are more the gradually acting forms. You may have heard the terms peak and trough, which is the highest and lowest amount of medication in the body. And you can see the advantages of an extended release product by staying at consistently higher amounts in the body for longer periods of time than the immediate or fast acting versions. And understanding these drug formulations is important for medication timing, because you realize how long a dose will take to kick in and wear off. For example, you see the light blue line there is the fast-acting Sinemet. It kicks in about 15 minutes, it peaks, and then it starts to wear off, where the controlled release, the red line, it takes a little longer to kick in, about 45 minutes, and then more gradually wears off. And then the Stalevo is the purple line, which we talked about is that combination product with the carbidopa, levodopa, and entacapone, which is the COMT inhibitor. So the entacapone helps prevent the breakdown of the fast-acting Sinemet. So it has that part where it kicks in, and then it can help extend that to last a little longer. And then there are the extended release forms. So these are the Rytary and the Crexont, which are shown better here on the right-hand graph. They both have faster acting beads in them and extended release beads, so it allows them to kick in within about an hour and then last for the longest of the oral levodopa products available. And aside here, it's also important to always talk to your pharmacist before breaking or crushing your medications because you don't want to damage how the medication is released in the body. For example, if you crush an extended release bead, it will break the integrity of that bead and cause it to dump the medication all at once, which could potentially lead to side effects. And overall, every patient with Parkinson's has a different experience finding the right balance of medication, the right dose, the right timing to best control their symptoms without causing bothersome side effects. So I call that maximizing the time in the therapeutic range, which is that Goldilocks, not too much or not too little. And so this is actually a good segue into our continuous infusions. So I know a lot of you many have questions. You may or may not have heard there are now 2 infusion pumps available for Parkinson's disease that are FDA approved. We'll first talk about Vyalev. We actually had our first patient at UC Davis start on Vyalev just over a year ago. And unlike pills that you take by mouth throughout the day, the Vyalev pump uses this device that delivers the medication continuously throughout the day and night via a small needle inserted just under the skin. That ideally helps smooth out the drug levels in the body and reduce the fluctuations that can lead to either too much or too little medication that can come along with oral dosing. So it's kind of like an insulin pump for diabetes management. And this pump device, the Violev, it's the size of about two stacked cell phones. It weighs less than a pound, and you can carry it around with a waist belt, a vest, or a similar carrying case. The medication itself comes in vials that you load into these single-use syringes into the pump, and then the pump is programmed based on your individual medication needs. And that medication pump and all the associated supplies come through a specialty pharmacy. And then there's a nurse ambassador that comes from the company that makes Violev called AbbVie. They come to your house and they train you and your care partner on how to use it all before getting started. And so some clear advantages of this medication is it is infused under the skin. So it bypasses the stomach, which is nice because there's no food interactions. It can tend to reduce the risk of nausea or constipation from oral levodopa. It also has that continuous medication delivery that helps minimize that peak and trough effect we're talking about with oral dosing, and also the pill burden associated. And it also helps minimize those motor fluctuations, thereby just having overall more stable symptom control and continuous coverage. And by giving a smaller amount of medication more frequently, it can also reduce the side effect potential from those potential peak effects. And as mentioned, the Violev pump rate is actually calculated based on your individual current oral medication needs. So it'll continue to be fine-tuned to match those needs. So if you're experiencing any adverse effects from too much or too little dopamine, the pump rate can be reprogrammed to your needs. Some possible drawbacks of the pump, besides insurance and cost barriers, being just a higher learning curve to using the associated pump functions and incorporating it into your routine, wearing it around, as well as the potential for the infusion-related site reactions and skin infections. This actually has been the biggest thing that we've seen. And then also, since it's still the same active ingredients overall, it's has the potential for similar side effects to oral levodopa, depending on the dose and your individual response. And then the other infusion pump available is called a NAPCO. It is similar to Violev in that it delivers medication continuously under the skin, but instead of dopamine, it's a drug called apomorphine, which is a dopamine mimic, so one of those dopamine agonist class. Therefore, unlike Violev, it's not a replacement for your oral carbidopa-levodopa based therapy. It's in addition to, you have the continuous infusion pump in the background to help with off time throughout the day. So yeah, different treatments there. So as a pharmacist, my main goal is always to ensure that the benefits of a medication outweigh the risks of side effects, especially with PD management. In Parkinson's, it's all about symptom control. So the goal is to maximize the medication benefit and minimize the potential side effects, preserving function, quality of life, and of course, safety. And so here's just a summary of the treatments that we discussed for the movement-related symptoms of Parkinson's, broken down by the classes. You'll have these slides available to reference back to, so no need to get overwhelmed over this here. And so now let's just stop briefly to digest this information. What I really want you to get out of all this is, since Parkinson's is basically a lack of dopamine, so how do we get the right balance of dopamine back in the brain? With these medications to restore the function and quality of life without tipping it over the edge, customized to you. And also importantly, while patients can gain insight from each other, all people don't respond to medications the same way. So each regimen is highly customized based on your individual response and tolerability. So for any questions so far, feel free to take a moment to write them down or place them in the chat so that we can review them at the end of the presentation.
John, can you repeat the question, please?
What I'm curious is as Parkinson's develops over time, the dopamine level lowers. how do we assess when to take more medication contingent upon the lowering of the dopamine, but yet not get into dyskinesias where we're overdosed? And how do we know when to do it, and how do we know how much to increase it by?
Yeah, so do you want me to answer these questions now or should I wait till the very end? Because I may address some of these things in the second part of the presentation.
No.
Let's answer that one now.
Yes.
Okay, so I mean, yeah, to answer the question about if you're progressively losing more dopamine over time, how do you know when it's time for more levodopa and to not push it over the edge either? I think again that comes down to your individual regimen. So, you could, if you are losing more dopamine over time and your medication doesn't seem to hold the way that it used to, as far as when you take a dose, you might need more medication per dose, or if it's wearing off too soon, you might need it more frequently. And so fine tuning either the amount that you take per dose, the timing of the day that you take it, or by changing to one of the different formulations so that it extends differently as far as lasting longer between doses, or even in some of the advanced phases, progressing to one of the pump medications. So the Vyalev can really help minimize those motor fluctuations as far as tipping it over the edge and keeping it in that continuous range. And I'm just talking about the medication aspect. There's also like deep brain stimulation, other things that are used as part of your comprehensive treatment plan as well. But from a medication standpoint, kind of playing into the medication options we have available. So I'll pause there. That was a good question. I know there's more questions coming in through the chat, and I'm sure you have more that you're writing down. But let's shift gears to the second part of the presentation, and then I'll have more time for questions at the end. So I want to shift gears a little bit to talk about individual medication schedules. So medication timing is very important for the management of Parkinson's and balancing our dopamine levels. So, as many of you know, people with Parkinson's are generally taking medications multiple times a day to stay on top of their wearing off and their symptom return, which can be difficult to remember and to fit into your daily schedule, especially in the middle parts of the day when you're out and about. And so you can see here there's different ways that are helpful for people to remember to take their medications, whether that be creating routines, setting alarm reminders, written calendars, and or having those people that hold you accountable to stay on track. So feel free to write down or put in the chat if you have a good strategy for yourself to remember to take medications, and we can review those later as well. But this also ties in well to the question of how do I time these multiple times daily doses of medication around eating my meals that also happen multiple times a day? I've had so many patients tell me that they're very overwhelmed with the timing of their medication around meals. And so, as a general rule, I say try to separate those oral doses by an hour from food or meals with larger protein and calories just to maximize the absorption of the medication. And that's really just to get the greatest bang for your buck, since the risk with taking the levodopa at the same time of high protein meals is reducing the effectiveness of that dose of medication and leading to more off time. But there's also what I like to call the light snack method. So this is for if taking levodopa on an empty stomach causes nausea. If you take it with a smaller low protein snack, such as crackers or a piece of fruit or toast, it's usually fine, and it can help with tolerability and won't interfere as significantly. But overall, it's still important to not avoid protein since it is essential for our overall health, our muscles, and our energy levels as well. Okay, so now the fun part, medication side effects. Instead of going through each drug and drug classes side effects, I'm going to talk about side effects that can occur kind of as a whole from too much dopamine in the system. We already discussed dyskinesias briefly, or the wiggles that I called it, being a complication that can occur from too much dopamine. It can be scary or overwhelming to look on the internet and all the potential side effects that a medication can cause. However, as a pharmacist, it is my job to make sure that the risk of these side effects is put into perspective in terms of the real world likelihood of it occurring and then how to manage it. So it's helpful to keep a journal or a chart when you start taking a new medication. Also, when you have a change in the dose of a medication or in the frequency or in the timing. And this can all help you decide what's working and what's not working and potentially causing a side effect. Because oftentimes all it is needing to make an adjustment to the dose or the frequency or the timing. For example, that in and of itself might help reduce that side effect. And it's also important to recognize that many medication side effects can also be symptoms that you were already experiencing as a result of Parkinson's disease itself, unfortunately. So, for example, about 20 to 40% of people with Parkinson's report experiencing hallucinations or delusions, and this could be as a result of disease progress, any sort of acute infection or illness, a stressor, or medication contribution or other potential factors. So other, we touched upon impulsive behaviors that can also occur with too much dopamine as well. We did say they are more common with the dopamine mimics or the agonist class, but they can also happen just due to excess dopamine from other classes. And so it's important to talk about these things because they can be bothersome and real side effects, and we could potentially help address them if they're talked about. But again, when we talk about medication side effects, it's also important to recognize that these side effects could be symptoms of the Parkinson's. For example, the low blood pressure with position changes can happen in about 30% of people with Parkinson's, because similarly to having low dopamine levels in the brain, there's a brain chemical called norepinephrine that can be in lower amounts in people with Parkinson's. And norepinephrine actually helps regulate our blood pressure. So drops in blood pressure can occur, especially with position changes like sitting to standing. And this could be exacerbated by the medications as well. And this can lead to dizziness and lightheadedness, which the main risk there is having falls as well. And so here, along the lines of medication side effects, you probably all have had a question about, is XYZ safe to take with my other medications or with Parkinson's disease? And we'll spend a bit of time here because I think many of you have had similar questions. So let's say you're experiencing a cough or a cold. You've likely gone over the counter at the pharmacy or online to help with the symptoms that you're experiencing. So you have a cough, you're looking for a cough suppressant. There's one called dextromethorphan. You may have been told you shouldn't take that if you have Parkinson's or if you take certain medication. But this warning, it actually has to do with the non-selective MAO inhibitors that I touched on briefly, because higher doses of dextromethorphan can increase this brain chemical called serotonin and increase the risk of something called serotonin syndrome. However, this medication class for Parkinson's disease treatment is MAOB specific, which I mentioned is selective for dopamine, not serotonin. So the risk of the serotonin syndrome with this combination is very minimal, especially in the doses that you use with dextromethorphan as needed for your cough symptoms. So more often, the benefits in helping with that short-term cough could outweigh the potential risks of the drug interaction. And similarly, let's say you have congestion as a result of the cold and you're looking for a decongestion. And you have heard of pseudoephedrine, maybe you increase, or you heard of pseudoephedrine at the pharmacy, and you can hear that it increases a brain chemical called norepinephrine, which we talked about briefly, that can increase blood pressure and heart rate. So this is the same kind of interaction warning as before with the non-selective MAO inhibitors, because these medications prevent the breakdown of these brain chemicals, so they have more of it hanging around. So more norepinephrine can lead to higher blood pressure and heart rate. However, again, MAO be specific selective for dopamine, not norepinephrine. So at lower doses of these decongestions that you need for congestion, the risk would be very minimal and potentially would outweigh the risk of the benefit would likely outweigh the risk with this combination. But the main thing that I will say about drug interactions with cough and cold products is to look at the ingredients list closely and caution against those super broad combination products that have more things in them than you actually need. For example, most of our branded cough and cold products, for the nighttime version, they contain a sleep aid in the form of an antihistamine, which is an allergy medication, which I'll go into more detail in a bit, but essentially, antihistamines are, they cause side effects in Parkinson's similar to those anticholinergic drugs that we mentioned before, those drying effects, constipation, confusion, memory issues. So I would caution those in Parkinson's as a whole. And other common questions that I get are about uh, what can I take for pain for with Parkinson's disease? The main drug interactions to watch out for there are for prescriptions like such as narcotics, because these can cause confusion and drowsiness and hallucinations, as well as constipation, which, can also exacerbate problems already happening in Parkinson's. There is a class of medication over the counter, the nonsteroidal anti-inflammatories. So you've probably heard of ibuprofen or naproxen. These don't have drug interactions with Parkinson's per se, but they can be hard on the stomach, and the kidneys and the heart. So it's important to, one, to take them with food if you're going to take them at the lowest dose for the shortest time possible. And then they're not recommended if you have certain history of heart and kidney disease. So that's just another note. But Tylenol, which is acetaminophen, does not have interactions with Parkinson's disease, and it's usually safe and doses up to 3,000 milligrams a day. So this is generally the safest option for as needed pain management that we use. And then vitamins and supplements is kind of the next grouping I want to talk about. So for people that eat a balanced diet of fruits and vegetables and whole grains and lean proteins, in general, they don't really need extra vitamins and supplements, and it is usually preferred to get these from food. However, in certain cases, especially if you do actually have a deficiency or a low level of a certain vitamin, supplementation can be beneficial to replete those low levels. Some common deficiencies I've seen in patients with Parkinson's that can be confirmed with blood testing are vitamin D, B12, B6, and folate. And the biggest thing overall is, since vitamin and supplement products are not regulated in the same way that prescriptions are by the FDA, they could have more or less of a certain ingredient than stated on the label. However, there are certain brands that have been third-party tested for purity, so it's recommended that you look for that stamp of approval whenever possible. And then for drug interactions with vitamins and supplements, taking iron. So multivitamins sometimes have iron preparations in them. And for example, taking them at the same time of carbidopa, levodopa does have the risk of decreasing absorption, making it less effective, which in turn can help or can worsen the Parkinson's. So it is recommended to space those iron pills by at least 2 hours from your oral carbidopa levodopa doses. Okay, let's talk about allergy medications briefly. So, as mentioned, antihistamines, being in many of the cough and cold preparations, can cause the side effects that people with Parkinson's may be already experiencing. So, ingredients to watch out for, one, as seen on the screen for the sleep aid, diphenhydramine. So that one is often in the nighttime preparation of branded products, or in sleep aids, which I'll touch on in a second. But the newer generation, so non-drowsy allergy medications, are typically safer. So loratadine is a common one, or fexofenadine. Those tend to have less of the cognitive side effects. And then, of course, if you're just having runny nose, you could start with just a nasal spray like a Flonase or fluticasone, because it's locally concentrated to the nose, so they're less likely to get absorbed and cause some of the side effects from taking a medication orally. So back to the sleep aids, a reminder about the importance of looking at ingredients when it comes to sleep aids. The antihistamine concerning for the Parkinson's, the diphenhydramine can cause the confusion, dizziness, brain fog, sometimes constipation as well. And there can be other ingredients added to sleep aids as well, like herbal products. So you may have heard of valerian root or ashwagandha that can be added and have some drug interactions that can contribute mainly for drowsiness and hallucinations. It could also have some blood pressure lowering effects as well. Because these products essentially slow the way that the body's control center is, so it causes some of those slowing symptoms. But melatonin is alternatively a safer option for sleep for people with Parkinson's, as it is a hormone that the brain produces that helps control our sleep cycle, and it can help with sleep quality, and it has a relatively good safety and tolerability. So typical doses I see for people are between 3 and 12 milligrams daily at bedtime, and there are actually extended release versions available that can be helpful. But speaking of herbal products, as mentioned with the vitamins and supplements as a whole, there is a lack of standardization and regulation, unfortunately, which can be a concern. So one particular product I wanted to call attention to is called Mucuna or Mucuna pruriens, which actually contains about 7% of levodopa by weight. There's no standardization to the product to ensure you're going to get the same amount of levodopa every time. And so people with Parkinson's being sensitive to precise dosing of levodopa, it can be risky, especially if you take it in combination with a prescription levodopa product, especially with regard to any of those levodopa related side effects. So just a caution there. And then the alcohol interaction is actually mainly, I mean, it's mainly with Parkinson's itself because alcohol can also slow down your system. It can impair coordination and balance, dizziness and drowsiness. It can also could potentially lead to some confusion. And so it can be exacerbated by certain medications. Especially there's one, the Crexont, the extended release carbidopa levodopa actually has a specific warning on their label to not take it with alcohol, and that's because when they studied it with high alcohol content liquors, and it broke the extended release properties of the Crexont and caused it to dump the medication, which can lead to side effects and not work as well. The medication didn't work as well either. And then lastly, I just wanted to touch on the CBD and THC products. So cannabis, CBD or cannabidiol is the major non-psychoactive component, while the THC is the major psychoactive component. And there is insufficient evidence to support its recommendation in clinical practice at this time, just due to the lack of good quality data. There have been many smaller scale studies that have had conflicting benefits and risks. But similarly to supplements, the CBD manufacturing process is not regulated in the same way. So there could be products with higher amounts of THC than advertised, which could then in turn lead to some side effects, like the dizziness and drowsiness, and even some of the paranoid thoughts, as well as impaired coordination and memory problems. So we spent a lot of time on interaction questions. Hopefully this helped answer a lot of your interaction questions, but we, can always come back to these later on. And then emerging therapies. So I always like to talk about what's new on the horizon in the Parkinson space and ongoing clinical trials. There is a medication that's likely to come in the first half of 2026. It's called tavapadon. It's a once daily oral add-on treatment to carbidopa levodopa. But there's also an infusion medication that's being studied as a potential for actually slowing disease progression of Parkinson's. But this one does have a lot of practical considerations to determine its actual clinical utility in the real world and, as mentioned, still in studies. And so I also included some ongoing clinical trials available that you could check out for enrollment eligibility here. Oops, I did not mean to click on that specifically. Okay, so then here we have our medication cost and access. So actually, we'll go back here. Medication cost and access. So I want to shift gears here because you may be wondering why medications are so expensive and what to do about it. For example, brand name Norians, cash pay without insurance can cost over $2,000 a month. And there are oftentimes financial assistance programs available to lower your out-of-pocket cost. So there's charitable foundations that have grant funding available to help with the cost of certain medications for people who qualify. The drug makers also provide coupons for brand name medications that are applied at the pharmacy to lower out-of-pocket expenses. And then there's also patient assistance programs that are put on by the drug manufacturer that also aim at reducing the cost of the drug, and they're usually based on income and needs as well. And so here, there's other ways to lower drug prices, such as through the Mark Cuban Cost Plus Drug Company, as well as GoodRx coupons. The caveat to this is that these are mainly for generic medications. So there's a limited number of brand name medications available, and even so, they can still be expensive. But speaking of generic drugs, Rytary actually had its first authorized generic become available as of August of 2025 by a company called Zydus Pharmaceuticals. It's now orderable by pharmacies, but we still don't know the price point yet. I'm unsure of how much it's going to cost relative to the branded product, just due to insurance contracting and things. So more to come on that. But Mark Cuban's cost plus model is really just about selling generic drugs at the cost of the drug plus a small markup without the barrier of insurance, while the GoodRx model generates a coupon that you can use at the pharmacy counter. It's not through insurance at all. So unlike manufacturer programs, they don't have eligibility criteria or activations or restrictions on how many times you can use them. You just pull them up at the pharmacy counter and have them apply the details. But for both the Mark Cuban and the GoodRx, you can type in your drug name that you're looking for, as well as the strength and the quantity to see what's available and to compare the prices. The main difference between the Mark Cuban and the GoodRx is that Mark Cuban, you have to create an account with their mail order pharmacy to obtain the medication, whereas GoodRx, you get at the local pharmacy, you apply the coupon, you can select between the option that works best. For example, if you live close to a Costco pharmacy, you want to find the lowest price at Costco pharmacy only. And so here's a summary of some of the more common medications used to treat Parkinson's and the estimated cash price through a drug discount like Mark Cuban or GoodRx, as well as the brand name cost cash pay. But to orient the table, it's by drug class and then the generic and brand name listed. The cost here, though, is a rough estimate because a lot of these prices are continuously changing based on drug contracts. Also, the number of tablets or capsules you'd need for a 1 month supply of medication as well. So it's very variable. And so this visual may look overwhelming, but I'll break it down briefly, and we're wrapping up here as well. So this summarizes the different options available to help with high medication costs based on your individual situation. So for example, let's say you don't have any insurance. Your options are pretty much paying cash, which we talked about the Mark Cuban or GoodRx options, or sometimes based on eligibility, you may be able to qualify for a brand drug manufacturer patient assistance program. But if you do, let's say you have commercial insurance, for example, and your insurance approves a branded drug, through your insurance, you can potentially qualify for the manufacturer's copay card. But that does not apply to government insurance. You can't use a copay card with government insurance, such as a Medicare plan. So if you have a Medicare Part D plan, which is the prescription drug cost, or this prescription drug benefit part of Medicare, based on your eligibility, you actually may be able to qualify for one of the manufacturer patient assistance programs or a charitable fund. So if you want to try those options first, and then if not, there's actually some exciting Medicare reform. So Medicare Part D for 2026, the maximum out-of-pocket expense for all of your prescriptions over the course of the year is $2,100. So there's an option to actually enroll in a prescription payment plan, which spreads the annual drug cost into monthly installments of $175 per month. So you wouldn't have to pay it all at once. So that would be your maximum drug cost per month for the entire year. So we went over a lot of information today. I want to summarize some key points. Medications are helpful to treat the movement-related symptoms of Parkinson's, carbidopa-levodopa forms being the foundation of treatment, and then tailoring it to your individual factors. Most drug treatments work by increasing dopamine, mainly by directly replacing it, preventing its breakdown, or activating the parts of the brain that replace dopamine, among other pathways. Medication-related side effects can also be symptoms of Parkinson's itself, so it's important to recognize and track patterns when starting new medications or making adjustments, so that ultimately we can find the best balance of medication for you. And also be open with your healthcare team, sharing all your symptoms, how well your medications are working for you, and any suspected side effects, so that we can really just ensure that each medication's benefit outweighs the risk, because it's all about maximizing function and quality of life. So with that, thank you so much for your time, and I am happy to answer questions at this time.
Is the pump better than Crexont?
Is the pump better than Crexont? So that's it. Do you want me to answer them just one by one?
Sure.
Okay. So better is a tricky term. I think it's based on the issue. So typically we use Crexont before we would escalate to the pump, because one, it is an oral therapy that, if you're able to be controlled with oral therapies first, then typically the pump is reserved for more advanced motor fluctuations. So you're having too much or too little of the medication. And if you can control that by, just converting from a fast-acting form of carbidopa, levodopa to an extended release form first, like Crexont, then that could be an easier option to start with. And so oftentimes we'll use Crexont as the first step, and then while we're applying for patients to potentially get the Vyalev pump, because Vyalev can take a long time to even get insurance approval and then coordinate with the specialty pharmacy that's going to be delivering the supplies, and then the training, and then actually getting started. So I've had people where I've converted to Crexont in the meantime, which has been a helpful step. But then if they're still having issues, then potentially going to the pump next, since it is a continuous infusion. So theoretically, it helps control those motor fluctuations better than any of the oral drugs out there like Crexont.
Thank you.
And how difficult is it to transition from carbidopa, levodopa to Crexont?
How difficult is it? So it depends on, it's not difficult as far as like an actual, like it's a direct overnight switch. So oftentimes when I transition my patients from the fast acting carbidopa, levodopa, the IR to Crexont, I typically do it. Well, first it's about getting the right calculation for what the Crexont dose is going to be. And so making sure that, your provider that's doing that is familiar with how to dose the Crexont in relation to how much of the carbidopa levodopa you're currently on, to try to get a good guess of what your equivalent would be. And then usually what I do for the conversion is you would take your last dose of IR carbidopa levodopa at the time you normally would that night. And then the next morning, when you wake up in the morning, instead of taking your IR, you would transition over to Crexont. So it's not difficult as far as like the actual transition process. It's just about finding the right dose.
The last one on Q&A. Trazodone, okay to take as a sleep aid, along with levodopa. And
Yeah, so I do have plenty of patients that take trazodone as a sleep aid along with their levodopa and amantadine. The risk with those ones would just be monitoring for any excess drowsiness. I mean, the purpose of the medication is for drowsiness and dizziness, as well as any kind of brain-related cognitive symptoms. So as long as, you typically with trazodone, you would start at a very small dose to take as needed to help with sleep, and then you could increase based on tolerability and effect. But I do have patients that take that combination, and it has been working for them.
okay, there's another one here, but George in the room has a question.
How important is it to take the medication at the same time every day?
Yeah, that's a great question. I think for consistency, taking medications at the same time of day every day is very helpful as far as minimizing those fluctuations that I mentioned. Because sometimes all it is that irregular dosing of the carbidopa levodopa is leading to either too much or too little. So keeping to a consistent schedule can be really helpful for overall symptom control. But it also depends on the person. Like some people will know when they're due for another dose of medication, and so they have to be on time, or they have symptom returning. But for people that don't notice that wearing off effect as much, then that's when it's more up to you to keep on track of the schedule. But also, in the real world, it's reality. There's going to be times where you're late on doses, and if that does happen, which it will to everyone, that's fine. It's just making sure to readjust for that. So let's say you're taking your doses at every 4-hour intervals and you're late on a dose, you take it then readjust your 4-hour interval to prevent dose stacking. That's usually most effective.
Charlene.
You had mentioned in one of your slides about, starts with a P, it's a intravenous, fusion,
Hmm.
medicine. Do you tell me a little bit more about that?
Yeah, so that one's called Prastinumab. It's a 4-week infusion. It's a medication that is working at the actual biology of what they think is happening in Parkinson's. One of the things to do with the alpha-synuclein, which is a protein that can tangle and build up, that they think could be leading to the disease process of Parkinson's. So it's kind of like some of the drugs that have been studied in Alzheimer's for removing the plaques in Alzheimer's. It's kind of that approach, but for Parkinson's, getting at the actual biology of what's happening in the disease. But as mentioned, this is something that's invasive. It's a every 4-week infusion, and it's also still in clinical trials. So we don't know if clearing out these alpha-synuclein proteins is actually going to manifest in the real world to slowing the disease progression and in turn reducing symptoms. So it's in trials. It's in a potential. It's exciting because it's a medication that could slow disease progression, but there's still a lot that we still don't know about the real world implications.
Thank you.
Mhm.
Yes, I was just wondering, I kind of have some issues with listening to my pharmacist as compared to listening to my doctor, and I'm trying to balance everything up between the three of us, you know? So if I get different information from my pharmacy, should I definitely address it with my doctor immediately or the next appointment? It might be like 4 to 6 weeks out.
Yeah, that's a great question. I think it's different because my job, I work directly with the neurologist in clinic, so it's a little bit different than getting advice from the retail pharmacist, who doesn't work directly with your treating neurologist. So I think, yeah, I would recommend, bringing it up to your treating neurologist since they are the one managing your medications. You can say this is what the pharmacist at the pharmacy told me, but oftentimes I think because I work directly with the neurologist, we're part of the same team. So we're usually providing the same advice, or more so, the neurologist will ask me in clinic to provide that same advice. So it's a little bit different than getting advice from the retail pharmacist, which I would bring back to your neurologist.
Okay, thank you. Any other questions in the room? Yes, John.
With Crexon, some neurologists say you could take carbidopa levodopa with it to increase the dosage when you get. Do you take slow release, immediate release, or extended release with it?
Oh, that's a great question. So we have found that, especially if Crexont for you doesn't kick in fast enough, I have some patients that will take the fast-acting carbidopa levodopa between doses of Crexont as kind of a kickstart. So let's say the first thing when you wake up in the morning, you take a half a tablet or a full tablet. Oftentimes you can start with just a half tablet of the fast-acting, the IR carbidopa levodopa to help kickstart while your Crexont dose is kicking in. The good news about the fast acting carbidopa levodopa is it's fast on and fast off as well. So the issue with taking multiple controlled or extended release forms at the same time would be dose stacking. So that could increase side effects. But if you use the fast acting in between, that can help bridge those gaps and just act as a kickstart.
I think that ties, hold on, John, one question here. What leeway does a patient have to increase or decrease the amount of drug he's taking depending on symptoms?
Can you clarify, is this in terms of on their own or in collaboration with their treating healthcare team?
Probably, Linda, you can answer that. Is it on your own?
Yeah, so oftentimes, at least for my patients, I'll try to prevent them doing things on their own just to maximize safety, but I'll give them a lot of different recommendations. So you can ask your team, if this doesn't work, do I have the option to do this? So a lot of times we'll have people, start with, just one tablet 3 times a day, and then as tolerated, increase to 1.5 tablets or increase to 4 times a day or different spacing. So you can ask your team if there's different options that you have if that doesn't work. Like let's say, I try this thing and I have more symptoms. What are the next steps? So being more forward thinking in your visits so that you can have leeway at home when you go home. They'll have like 3 different options available that have been discussed with your treatment team.
That's great, thanks. George?
What is pramipexole dihydrochloride?
So that pramipexole is one of the dopamine agonist class. So that's the dopamine mimics. The hydrochloride is just the salt form that they tack onto it, but that's pramipexole. That's the dopamine agonist. So that's the drug class that we talked about. That's the that mimics the dopamine and can increase levels in that way. The one that does have the higher risk of the impulsive behaviors and excess dopamine, but it also is all based on your tolerability as well.
John, did you have another question?
Do you have any information on peptides? There's some stuff floating around that they may have some benefit for Parkinson's patients.
Are these like supplements? What type of peptides? Like collagen peptides or?
They're saying different peptides have different results with different circumstances or situations.
Yeah, that's a good question. I think overall, we haven't recommended any of the peptide products just because, similarly to how I was talking about supplements, they're not regulated in the same way that the prescriptions are. So, I mean, it all is a benefit versus a risk discussion with your treatment team. So, if you bring, a new thing that you found that some people find effective and you bring it in and show your team and see if it's something that you want to give a try, it's all a benefit versus a risk. But in general, I haven't seen that recommended in my practice at this time.
Question, the fellow in the hat.
Ask questions probably out of the scope of this meeting, but we talked about cryotherapy where they're doing treatment and going in to the brain and affecting an area of controls, tremors and this type of thing. Parkinson's. Do you have any experience in that area?
That's a good question. Not specifically in that area, but I know there are a lot of really interesting and exciting things happening outside the realm of medications that I'm sure a lot of my colleagues that, specialize in those things would be probably better apt to answer those things. But I know there are different, so that actually might be in some of the clinical trial finder that you can specifically look at things happening outside the realm of medication management to treat Parkinson's. So definitely feel free to ask around other specialists that in those areas.
Do you have a website where we can contact you and ask you questions if we have any?
I don't specifically have a website. I do have an email address that I could potentially provide for questions. I will say that while I do work, full time during the week, but if there's anything that I can be assistance for, if you want, or if you ever want me to come back for further lectures or even like smaller group sessions, I'm happy to entertain those discussions.
Thank you.
Our corner. Yes.
You mentioned earlier the iron interaction concern with multivitamins. I'm kind of doing a little check. Seems like almost all my multivitamins will have some form of iron. So my question really is there a level to which you need to be concerned? Like, is it above 100% of your daily requirement, 50%, or what do you think?
Yeah, that's a great question. I think typically it's so the lower the amount of iron, the lower the risk of interfering with the absorption, especially if it's a multivitamin that contains so many other things as well. The pure iron form is the one that's the highest risk of decreasing the absorption of the carbidopa levodopa. So if you're able to space out even the multivitamin that contains smaller amounts of iron, you may get more bang for your buck. But again, it's, in the real world practice, I'm not sure how much of a difference it would make.
Just to tack on to that question about the iron, would that hold true for the Violet also?
No, it does not apply to the Violev because anytime you're not going through the oral route, you're bypassing the where it is absorbed in the small intestine, you're going straight infused in through the skin. So it bypasses all the drug and food interactions because of how it's delivered.
Thank you so much, Dr. Berkley. We are so happy that you came. We're so happy for your patients and the way that you.
Absolutely. Yeah. Thank you all so much for your active engagement. And let me know how I can further assist this group from afar. Have a great rest of your weekend, everyone.
You too. Thank you.
Bye.